Hello friends, welcome to the video tutorial on ID Week Abstract 1959 of plea clinical trial. So this is the third video on the series of the video tutorials on the abstracts of plea clinical trial. So abstract 1959, the objective of this abstract was to assess the clinical and microbiological outcomes in patients infected with ceftriaxone non-susceptible, MDR and ESBL producing gram-negative pathogens at baseline. So for the patients infected with either ceftriaxone non-susceptible or MDR or ESBL producing gram-negative pathogens at baseline. So this study was conducted with an objective to assess the clinical and microbiological outcomes in these patients. So the clinical cure and microbiological eradication was assessed in this abstract. So as we know that 230 patients were randomized in plea clinical trial, and out of these 230 patients, 143 patients constituted the MMITT population, that is microbiologically modified intention to treat population, and they have actually contributed to the biological specimen in this study. So the comparator drug susceptibilities, the results of the susceptibilities of these comparator drugs, they indicated that 140 out of 143 isolates, that is 97%, more than 97% of the isolates were ceftriaxone non-susceptible. 119 out of these 143, that is around 83% of the isolates, were ESBL producing isolates, and 100 out of 143, that is approximately 70% of the isolates are MDR isolates in this study. So just to recall, what is MMITT, that is microbiologically modified intention to treat population. So patients which has at least one baseline gram negative pathogen at 10 raised to power 5 CFU per ml and susceptible to both Elores and meropenem. So this particular population falls under the MMITT, that is microbiologically modified intention to treat population. And the inclusion criteria was susceptibility or sensitivity to both Elores and meropenem. So this is an important point. All of the isolates were susceptible to both Elores and meropenem. Now if we talk about the comparator drugs, so 4 groups of antibiotics were analyzed: aminoglycosides, different BL-BLI combinations, cephalosporins and fluoroquinolones. And in aminoglycosides, amikacin and gentamicin was analyzed. In BL-BLI combinations, piperacillin tazobactam and cefaperazone sulbactam was analyzed. In cephalosporins, cefepime and ceftriaxone, and for fluoroquinolones, ciprofloxacin and ofloxacin were analyzed in this study. So before moving further, let us again revise these terms: MDR, ESBLs, etc. So what is MDR? MDR is defined or MDR was defined in this study as resistance to 3 or more than 3 classes of antibiotics. So if any pathogen is resistant to 3 or more than 3 antimicrobials, it will be classified as MDR, or it was classified as MDR pathogen. Now ESBL, so ESBL was defined as a positive readout from the CDDT, that is combined disc diffusion test, as per the CLSI methodology, and CNS, that is ceftriaxone non-susceptible pathogens, as per the disc diffusion test. So what is this CDDT, combined disc diffusion test? So it is a phenotypic confirmatory test recommended by CLSI to identify ESBLs. So this test accurately detects ESBLs among Enterobacteriaceae species when no other potent beta-lactamase are co-produced. So as you can see in this image also, there are 2 petri dishes, and one petri dish is carrying the disc for ceftazidime, and second petri dish is carrying disc for ceftazidime plus clavulanic acid. So there are 2 discs, agar plates. One is carrying disc for ceftazidime and second is carrying discs for ceftazidime plus clavulanic acid. And after doing the disc diffusion test, if there is a difference of 5 millimeter in the zone of inhibition it indicates the detection of ESBLs. So if the zone of inhibition of ceftazidime plus clavulanic acid is at least 5 millimeter greater than the zone of inhibition of ceftazidime, it indicates the presence of ESBLs. So now coming to different pathogens and antibiotics analyzed, again different antibiotics like aminoglycosides, for example amikacin and gentamicin, then different BL-BLI combinations like piperacillin tazobactam and cefiperazone sulbactam, cephalosporins like cefepime and ceftriaxone, and fluoroquinolones like ciprofloxacin and ofloxacin were analyzed for different pathogens like Acinetobacter species, Enterobacter species, Klebsiella species, Pseudomonas species, Protease species, etc. So the susceptibility pattern of these comparator drugs were identified among these different pathogens, and also the clinical cure and microbiological eradication was evaluated for different resistant subgroups like for MDR, ESBLs and ceftriaxone non-susceptible populations among in between Elores and meropenem. So if we talk about the comparator drugs susceptibility at baseline among different phenotypes, so the majority of the isolates here were found to have all three resistant phenotypes, that is MDR, ESBL plus ceftriaxone non-susceptible. So 88 pathogens out of 143 pathogens, that is around 61.5% of the isolates were resistant to all three subgroups, that is MDR, ESBLs and ceftriaxone non-susceptible, and were categorized by the lowest susceptibility rates among these tested antibiotics, that is 2% to 49% only. As we can see, 88 pathogens out of 143 falls under this category, which are all resistant to all three subcategories of resistant groups, that is MDR, ESBLs and ceftriaxone non-susceptible, and the susceptibility of ciprofloxacin, it is only 2%, and the susceptibility of piperacillin tazobactam is 49%. So this is the range 2% to 49% susceptibility for these comparator drugs for this subgroup, that is MDR plus ESBL plus ceftriaxone non-susceptible. Also, this is another important point to note here, that the overall highest susceptibility was observed among the BL-BLI combinations, which is 66% to 68%. 68% for piperacillin tazobactam and 66% for cefiperazone sulbactam, which was closely followed by aminoglycosides, that is 54% to 58%. So gentamicin was 54% susceptible and amikacin was 58% susceptible. And a very high rate of cephalosporin and quinolones resistance was observed in E. coli, that is 99% to 100% and 84% to 89% respectively. So cephalosporin's resistance in E. coli was 99% to 100%, and similarly quinolone was 84% to 89% resistant. So this data again highlights a high rate of resistance in E. coli for cephalosporin and quinolones. So as we can see, cefepime is 0% susceptible, which means all of these pathogens were resistant to cefepime. Ceftriaxone was just 1% susceptible. Similarly, ciprofloxacin is just 11% susceptible and ofloxacin is 16% susceptible. Now here it is important to remember the inclusion criteria, which is sensitivity to Elores and meropenem. So all of these pathogens were susceptible to Elores and meropenem also. So if we compare the susceptibility profiles of different BL-BLI combinations like piperacillin tazobactam and cefiperazone sulbactam with Elores and meropenem, so definitely all of these pathogens are susceptible to Elores and meropenem, whereas the susceptibility profile of piperacillin tazobactam and cefiperazone sulbactam, it is very less, that is around 66% to 68% only. Now you can see here some of the blank spaces also at 4 places which are circled here. So it means that susceptibility is not mentioned here because the breakpoints are not available or defined for these pathogens and for these antibiotics. So we know that the most resistant subgroup, it is MDR plus ESBL plus ceftriaxone non-susceptible. So this subgroup is marked in yellow here. So the prevalence of the most drug-resistant phenotypes which are marked in yellow, it was highest among the non-fermenters. For example, Acinetobacter baumannii and Pseudomonas aeruginosa. So the prevalence of this MDR plus ESBL plus ceftriaxone non-susceptible, it was maximum in Acinetobacter baumannii, which is 100%, and then Pseudomonas aeruginosa, which is at 90%. So it is maximum or most prevalent in non-fermenters gram-negative bacteria. Now coming to the outcomes of patients across various resistant subgroups at TOC, at test of cure visit. So clinical cure and microbiological eradication was analyzed for different resistant subgroups like MDR, ESBLs and ceftriaxone non-susceptible. So the maximum of the efficacy, maximum clinical cure and microbiological eradication was observed in ESBL resistant subgroup. So the treatment effect was highest in ESBL subgroup. Here we can see the clinical cure of Elores for ESBL resistant subgroup, it is 100%. Whereas the clinical cure of meropenem in ESBLs, it was observed at 89.3%. Similarly, the microbiological eradication for Elores in ESBLs, it was 98.4%, and for meropenem, it was 87.5%. So this data clearly indicates that for ESBL infections, Elores is non-inferior to meropenem. And also in the MDR and ceftriaxone non-susceptible subgroup, non-inferiority of Elores at minus 10% margin was also observed for Elores as compared to meropenem. So if we talk about particularly this subgroup of ceftriaxone non-susceptible population, here Elores reported more than 95% cure rate in ceftriaxone non-susceptible subpopulation, proving the added synergy of this combination of ceftriaxone and sulbactam and disodium editate. Moreover, the susceptibility of Elores, which was 100%, because all of these pathogens were susceptible to Elores and meropenem. So the susceptibility of Elores, which was 100%, was much higher than other two BLVLI combinations, piperacillin tazobactam and cefiperazone sulbactam, highlighting the added effect of resistant breaking component disodium editate. So now coming to this important outcome of this abstract, the magnitude of fluoroquinolone and cephalosporin resistant Enterobacteriaceae was alarmingly high, that is more than 80%, warranting the need for superior agents. As discussed earlier, a very high rate of cephalosporin and quinolones resistance was observed in E. coli, that is 99% to 100% and 84% to 89% respectively. And another important outcome was overall the clinical cure and microbiological eradication rates were higher for Elores as compared to meropenem. So for all of the three subgroups, MDR, ESBLs and ceftriaxone non-susceptible, the clinical cure and microbiological eradication rates for Elores was greater than meropenem, which proves that Elores is non-inferior to meropenem for treating these kind of patients. Okay, so we can say that Elores demonstrated superiority over meropenem in ESBL producing isolates. As you can see in this image also, the clinical cure rates and microbiological eradication rates in the ESBL subgroup for Elores is superior to meropenem. So finally, it was concluded here that these results highlighted that Elores could provide useful clinical value as a carbapenem sparing option in clinical settings. And also we can conclude here that a right empirical antibiotic at right time and at right dose can make all the difference. So thank you friends.